Hello everyone, I am myself Dr. 𝐼𝐧𝐬𝐭𝐚𝐦. I am the General Medicine Educator. In this session, I will be discussing a very important topic, that is gout or the gouty arthritis. So first and foremost, you need to know gout is the disorder of purine metabolism, pyrimidine metabolism, ketone metabolism, the protein metabolism. So you need to know, this is a very important basic point. Gout, it is a primary disorder of the purine metabolism. Okay, so if you take the nuclear material, like we have the purines and as well as the pyrimidines. So but gout, it is the disorder of the purine metabolism. Now this particular gout or gouty arthritis, there will be increase in the uric acid levels. This is the important feature in gout or gouty arthritis, and so this increase in uric acid in the body, it might be due to two reasons in patients with gout. So one, it is either due to decreased excretion of the uric acid, right, or due to increased production of the uric acid. Okay, so these are the reasons why the uric acid will increase in these patients with the gout or gouty arthritis. And where is this uric acid coming from, right? What is the source of the uric acid? Please remember, uric acid, it is the final breakdown product of the purine degradation. Right? It is a final breakdown product of purine degradation. Okay, so that is a very important point regarding the source of the uric acid. So this particular gout, the reason why it will develop is it results from either increased production or impaired excretion of the metabolic end product of this purine metabolism, which is nothing but the uric acid. Now the next question is, what is the relation between the gout and as well as the hyperuricemia? The underlying basis of gouty arthritis is increase in the serum uric acid levels. So how much is the normal serum uric acid levels? If you see the normal serum uric acid levels, that is around 2 to 6 milligrams per deciliter. Okay, that is a normal serum uric acid levels. Now when the serum urate level is more than 7 milligrams per deciliter, then we call it as the hyperuricemia, right? So when the levels are more than 7 milligrams per deciliter, we call this as we call this as the hyperuricemia. So whenever there is hyperuricemia, what happens is this uric acid, it goes and gets deposited within the synovial fluid. Okay, so hyperuricemia is the one which will make the synovial fluid getting saturated with the uric acid. So whenever there is hyperuricemia, the synovial fluid it becomes saturated with the uric acid. That means the uric acid concentration within the synovial fluid increases. Okay, and once the uric acid gets saturated within the synovial fluid, that will favor the formation of the urate crystals, right? That will favor the formation of the urate crystals. So that means what? More is your serum uric acid levels, higher is the chance of development of your gout or gouty arthritis. So that is a very important relation between your gout and as well as the hyperuricemia. And the other point is, can you correlate between gout and as well as degree and duration of hyperuricemia? Yes, both of them, they are directly proportional. Occurrence of gout, it is directly related to magnitude and as well as the duration of hyperuricemia. So the occurrence of gout it is directly proportional to the degree of hyperuricemia and as well as the duration of the hyperuricemia. And higher the serum urate levels, the more likely an individual is about to get this particular gout. So I'll just give you the values also. The normal value is around 2 to 6 milligrams per deciliter. Okay, and when the serum urate levels are in the range of more than 7 to 8 milligrams per deciliter, let me tell you, the chance of developing gout is in 3% cases. Okay, in 3% cases, there is high chance of development of your gout when the serum urate levels are more than 7 to 8 milligrams per deciliter. And when the serum urate levels are more than 9 milligrams per deciliter, the chance of development of gouty arthritis is around in 22% cases. Right, around 22% cases. So that is a correlation between your gout and as well as the degree and duration of the hyperuricemia. So how is it? It is directly proportional. Okay, next. Then followed by that, so this is the basic introduction. What is that we have discussed? Gout is a disorder of the purine metabolism. So uric acid, it is nothing but it is the end product of the purine metabolism, and in gouty arthritis there will be hyperuricemia, and whenever there is hyperuricemia, the uric acid will go and get deposited within the synovial fluid, and thereby there will be formation of the crystals within the synovial fluid, where there is formation of the urate crystals. Okay, next. Right, you see another important question. All of the following statements about primary gouty arthritis are true except, right, which is the incorrect statement. 90% of cases are caused by overproduction of the uric acid. Second point, uric acid levels may be normal at the time of an acute attack. Men are more commonly affected than women, and definitive diagnosis require aspiration of the synovial fluid. So this is the question. So let me just take up the entire discussion and then finally come back to this question again. So you have to understand that first and foremost, this is a very, very important question. What is the most common joint which is affected in patients with your gouty arthritis? That is your first metatarsophalangeal joint. But before the involvement of your first metatarsophalangeal joint, let me tell you that the initial episode of gouty arthritis usually follows 10 to 30 years of asymptomatic hyperuricemia. Okay, so the initial episode, right, the initial episode of gouty arthritis to occur, let me tell you that there will be, right, there will be 10 to 30 years of asymptomatic right, 10 to 30 years of asymptomatic hyperuricemia will be there before the initial episode of your gout or gouty arthritis. Okay, and the other important point, so I have discussed about the joint. Okay, so yes, so the most common joint which is being affected is the first metatarsophalangeal joint. Right, this is a very, very important multiple choice question as well. Then followed by that, is there any role of measurement of the serum urate levels in the diagnosis? That is another important question. So, but before that, let me tell you, because of the involvement of metatarsophalangeal joint, what will be the clinical manifestations? The individual will have very severe pain in the first metatarsophalangeal joint, and not only that, you will have all the signs of inflammation. That is, there will be swelling within the joint, and as well as there is also redness that develops within the joint. Next, if you take the role of the serum urate levels in the diagnosis, definitely there is role of the measurement of the serum urate level in the diagnosis. But in what way it is useful, let me discuss. Actually, what is the basic hallmark? The hallmark is hyperuricemia. So, hyperuricemia, it remains the cardinal feature of gout. But the usefulness of hyperuricemia in the diagnosis of your gout, it is limited. Okay, why? I'll tell you. See, most of the patients, right, most of the patients with gout will have elevated serum urate levels. Right, will have elevated serum urate levels, no doubt in that. But the point is that this particular levels of the urate level, this particular urate levels may also fall within the normal range on occasions. When is that? I will tell you. So, the levels of the serum urate may fall to the normal level also. Right, may fall to the normal levels also on certain occasions. It may fall, in which occasions? Let me tell you, that is in acute attacks. So during acute attacks, the levels may fall within the normal limit. Now the question is why, right? Why the urate levels will be normal during the acute attacks? What happens is that urate, it goes and gets accumulated within the joint. Okay, that increased serum urate, whatever is there, it goes and gets accumulated within the joint, and that will cause an acute attack. So during that episode, if you do a serum urate levels, it may be normal also. This is a very important point you need to remember. So that is the reason why. Then what is the role of serum urate level in diagnosis then? The role of the serum urate is just monitoring the effect of the urate lowering therapy. Okay, so the role of urate is monitoring the effect of serum urate lowering therapy. Okay, so role of the urate is just monitoring the efficacy of the serum urate lowering therapy. That is the role of measurement of the serum urate levels. So that is, whenever you are giving serum urate lowering therapy, like when you are giving allopurinol, or when you are giving Febuxostat, or when you are giving like probenecid, how efficacious is that particular drug in reducing the serum urate levels? That is what is the role of the serum urate levels. But for the diagnosis, we don't take the serum urate levels as the investigation of choice. We don't take this as the investigation of choice. Okay, right. And actually, the underlying basis for gouty arthritis is increase in serum uric acid. But sometimes what will happen is in acute attacks, it may be normal. Okay, right. And you have to remember that in all the patients who ever develop hyperuricemia will not develop gouty arthritis. Okay, so it is only 1 in 4 hyperuricemic patients they develop your gout. 1 in 4 hyperuricemic patients they develop this gout or gouty arthritis. Okay, and hyperuricemia presents in approximately 5% of individuals, but vast majority of them they are asymptomatic. Hyperuricemia presents in approximately 5% of individuals, but vast majority of them are asymptomatic with regard to their hyperuricemia. So you have to understand that if 100 people are having hyperuricemia, it is only 25 people will develop this gout or gouty arthritis. Okay. Now, having said this, let me discuss the risk factors associated with the development of gout. So, I have said like it is not all the individuals with hyperuricemia will develop gout. It is only 1 in 4 people will develop this particular gout. Then what are the risk factors associated with the development of gout? That includes, so we have the non-modifiable risk factors and as well as the modifiable risk factors. So if you take the non-modifiable risk factors, that includes the male gender, right, that includes the male gender, then advanced age, right, advanced age of the individual. So if you take the modifiable risk factors that includes the following: an individual taking diet which is rich in meat and seafood, right, individual taking the diet which is rich in meat and as well as the seafood. Okay, and individual consuming alcohol containing beverages, right, individual consuming the alcohol containing beverages, and individual consuming sodas and fruit juice which is rich in fructose, right, which is rich in fructose. And the other important modifiable risk factor is the hypertension. And apart from that, we also have some drugs. I'll discuss that separately. Then obesity, is another important modifiable risk factor, and serious illness. Right, serious illness, it includes MI and as well as the stroke. Next, trauma, and next, surgery. So these are the modifiable risk factors. And non-modifiable risk factors, please remember, it is more common in males rather than females. And advanced age is another important non-modifiable risk factor. And these are all the modifiable risk factors. Now, you have to understand, right, now we will come back to this question now. So all of the following statements about primary gouty arthritis are true except. Now you take the second point, the uric acid levels may be normal at the time of acute attack, right? It is a true statement or a correct statement. And it is more common in males rather than females, that is also a correct statement. And please remember, what is the investigation of choice in your gouty arthritis? It requires the aspiration of the synovial fluid and examination of the synovial fluid. And next, which is the incorrect statement then? 90% of cases are caused by the overproduction of your uric acid is a wrong statement. See, the gouty arthritis, either it is due to overproduction of the uric acid or due to reduced excretion of the uric acid, and it is 90% it is not due to overproduction of your uric acid. That is a wrong statement. Okay. Now, having said this, yes, risk factors with development of gout are all except female gender, alcohol, thiazides and hypertension. So let me tell you, in the non-modifiable risk factors, I have taught you there. So which is the non-modifiable risk factor? That is male gender. Okay. So males, right, they are more prone for the development of your gouty arthritis than compared to that of females. Okay. And alcohol containing beverages, thiazides and hypertension, they are all the risk factors associated with the development of gout. Next, having said this, now let me discuss the drugs. Gout can be precipitated by calcium channel blockers, omeprazole, thiazide diuretics and then the digitalis. So if you take the drugs which will precipitate the gout or gouty arthritis, the very important drugs like what we have is the diuretics, that is thiazide diuretics. See, thiazide diuretics may increase the relative risk of gout by nearly up to 80%. Okay, the chance of development of gout when the individual is on thiazide diuretics is up to 80%. So now what does this thiazide diuretics do, right? How does thiazide diuretics increase the hyperuricemia? And it is not only thiazide diuretics, even the loop diuretics, both thiazide and as well as the loop diuretics will cause the hyperuricemia. So first of all, you have to understand that in the renal tubule, if you see like proximal convoluted tubule, loop of Henle, distal convoluted tubule and as well as the distal tubule. So out of this entire structure in the renal tubule, proximal convoluted tubule, it is the major site of the urate handling. Right, it is the major site of the urate handling. Okay, and this proximal convoluted tubule, it is involved in both. Right, it is involved in both. That is, it is involved in secretion of the urate and the absorption of the urate. Right, involved in secretion of the urate and as well as the absorption of the urate. Which one? The proximal convoluted tubule. Now, what these thiazide diuretics and loop diuretics do is, both of these drugs, they decrease the urate excretion. Right, they decrease the urate excretion. So how do they decrease the urate excretion? They decrease the urate excretion by increasing the urate absorption. So what they will do? They increase the urate absorption from the proximal convoluted tubule. So that is what is being done by your diuretics. That is what is being done by your diuretics. Both your thiazide diuretics and as well as the loop diuretics, they increase the urate absorption from the proximal convoluted tubule. So next question. So the gout can be precipitated by what? Your thiazide diuretics. And If you see the next question here, gout can be precipitated by all of the following except thiazides, furosemide, cyclosporin, and then the high dose salicylates. So the answer here is the high dose salicylates. Please remember there are two important things. One is the low dose salicylates, right? Low dose salicylates. And then we have high dose salicylates. So you take the low dose salicylate. Low dose salicylate means the dosage around 0.3 to 3 grams per day. So dosage of 0.3 to 3 grams per day, it is associated with uric acid retention. Whereas high dose salicylate, if you see, that is when the salicylate which is being used is more than 3 grams per day, this is uricosuric. Right, this is uricosuric. So high dose salicylates, please remember they are uricosuric agents. So high dose salicylates will not precipitate your gout or gouty arthritis. Whereas your thiazides and furosemide, just now we have discussed, they will increase the uric acid absorption from the proximal convoluted tubule. And even your anti-cancer drugs, that is cyclosporin and as well as tacrolimus, they are also associated with the hyperuricemia. Now let me just give you the list of drugs that will be causing the hyperuricemia. So drugs causing hyperuricemia, that includes number 1, diuretics. Right, number 1, diuretics, that is your both thiazides and as well as the loop diuretics. And the second important group of drugs is low dose salicylate. Then anti-cancer drugs, that is cyclosporin and tacrolimus. Right, cyclosporin and tacrolimus. And then we have anti-tubercular drugs, that includes pyrazinamide and ethambutol. Right, pyrazinamide and ethambutol. Then followed by that inhalational anesthetic drug, that is methoxyflurane. Right, methoxyflurane, it is an inhalational anesthetic drug. Then followed by that prodrug of dopamine, that is levodopa. This will also precipitate your gout or gouty arthritis. And then finally the laxative abuse. Right, then followed by that the laxative abuse. So these are the drugs which will precipitate the gout or gouty arthritis. And finally salt restriction. Then after having discussed about the risk factors associated with your gout or gouty arthritis, let me discuss the diagnosis of your gout or gouty arthritis. So the question is, specific test for gout is raised serum uric acid level, raised uric acid in synovial fluid of the joint, raised urea levels, raised urease enzyme levels. So if you take the diagnosis of the gout, investigation of choice will be synovial fluid examination. Right, investigation of choice will be synovial fluid examination. That will be the investigation of choice. Okay, or you need to examine the tophaceous material. And this synovial fluid examination, right, it is being done under polarized light microscopy. right? It is being done under the polarized light microscopy. So when you examine this synovial fluid in patients with your gout under the polarized light microscopy, what is that you will observe? You will observe the presence of a characteristic monosodium urate crystals. Right, you have the presence of characteristic monosodium urate crystals, and these crystals, when you observe under the polarized microscopy, what will be the shape of the crystals? Please remember, they are strongly negative birefringent, bright yellow needle shaped objects. Okay, so what is the shape of them? They are right, they are needle shaped. And what is the color of them? They are bright yellow. Right, bright yellow needle shaped crystals, which are negatively birefringent whenever you observe them under the, right, these are negatively right, these are negatively birefringent under the polarized microscopy. And you have to understand that during the acute attack, right, during the acute attack, this is a very important question, okay? During the acute attack, the crystals, they appear intracellular, right? They appear intracellular. Whereas once the attack subsides, right, once the attack subsides, then the crystals are extracellular. Right, the crystals are the extracellular. So this is how you will diagnose the gout or the gouty arthritis. That is the investigation of choice. So this is the image of the polarized microscopy in patients with your gout or gouty arthritis. So you can observe that is yellow needle shaped crystals. Okay. Whereas the image next to this, it is your calcium pyrophosphate crystals that is seen in patients with the pseudo gout. Right, that is seen in patients with the pseudo gout. So here, if you take the shape of the crystals, this will be a rhomboid shaped crystals. Right, this will be the rhomboid shaped crystals. Okay, whereas here in gout, it is the needle shaped crystals. So that is the difference between your monosodium urate crystals and as well as the calcium pyrophosphate dihydride crystals. Next, and the role of measurement of the serum urate levels. Yes, okay. In case of your gouty arthritis, definitely the serum urate levels, they are elevated. But already I have discussed in detail, in acute attacks, the levels may be normal also. So the greatest effect of measuring the serum uric acid is in monitoring the effect of the urate lowering therapy. Okay, so that's an important point you have to remember. Now, you take the synovial fluid examination, one is your monosodium urate crystals, but another important point you have to understand that because it's an inflammatory condition, so the leukocytes, they are elevated, right? So the WBCs, they are elevated in the synovial fluid examination, and the WBCs which are being elevated, they are in a range of 15,000 to 20,000 cells per microliter. So that will be the synovial fluid examination in patients with your gout or gouty arthritis, right? Next. Now, if you take the blood picture in these individuals, because it's an inflammatory condition, that is the reason why there will be elevated ESR and there will be also elevated C-reactive protein. And WBCs, if you see, even the WBC count is also elevated, right? There is elevated WBC. Now the next question is, the very important thing that is formed in the gout is the Tophi. So how is this particular tophi being formed? First of all, the pathognomic hallmark for gout is your tophi. So tophi is the pathognomic hallmark. Okay, so the pathognomic hallmark of the gout is the presence of the tophi. Now what does the tophi contain? Tophi, they are formed by large aggregations of the urate crystals. So there will be aggregations of aggregations of urate crystals. Now just aggregated urate crystals will not form your tophi. Along with the aggregated urate crystals, they are surrounded by intense inflammatory reaction of cells. Okay, so along with that, you also have the inflammatory cells. Right, you also have the inflammatory cells. And these inflammatory cells, they include macrophages, then we have lymphocytes, right, and then we have large foreign body giant cells. Right, large foreign body giant cells. So these are the component of the tophi, right, and tophi, they evolve from the repetitive precipitation of the urate crystals during the acute attack. Right, during the acute attack you have the urate crystal formation. So due to repetitive precipitation of the urate crystals during acute attack, the tophi are being formed. Okay, and on average it takes about 12 years between the initial acute attack and the development of chronic tophaceous arthritis. Okay, so on average it takes 12 years between the development of first acute attack and subsequent formation of chronic tophaceous arthritis. Okay, so this is about the tophi. So you have to remember that tophi means along with the aggregated urate crystals, you also have the presence of the inflammatory cells. Now, what will be the X-ray findings in patients with the gout or gouty arthritis? So the X-ray findings, you will make out that there will be a characteristic lesions. They are called as punched out lytic bone lesions. So you can make out here, right? So these are the punched out lytic bone lesions. Okay, so this will be one of the very important feature, and then followed by that, see, you have an overhanging sclerotic margin, and that overhanging sclerotic margin, right, it is nothing but it is Martel's sign. Right, overhanging sclerotic margin, it is nothing but a Martel's sign. Then followed by that, there will be osteonecrosis, and then the mineralization is normal. So this will be the radiographic picture in patients with the gout or gouty arthritis. So if you take the specific test for gout, the specific test for gout, it includes the synovial fluid examination, that is raised serum uric acid in the synovial fluid. Okay, raised serum uric acid is not taken as the investigation of choice. It is the raised uric acid in the synovial fluid of the joint that is considered as the specific test for gout. Okay, next, and even raised urea levels, it is incompletely correct statement. Raised urea levels, you will have that in patients with your chronic renal failure. Next, Followed by that, let me discuss the treatment in the patients with your gout or gouty arthritis. So before that, you see this question, true about gout is, occurs due to accumulation of urate crystals in the joint, can be precipitated by pyrazinamide, birefringent crystals are present in the joint, occurs more in females due to decreased excretion of the uric acid. So the true statement, like you have multiple options in this, okay, which are true. It occurs due to accumulation of the urate crystals in the joint, it is a true statement. It can be precipitated by pyrazinamide, that is also a true statement. Negatively, birefringent crystals are present within the joint, that is also a true statement. And it occurs due to decreased excretion of the uric acid, that is also a true statement. But occurs more commonly in females is the wrong statement because it is more common in males rather than females. Okay, next. Followed by that, let me discuss the treatment. So, you see a question regarding this. False regarding gouty arthritis is, synovial fluid analysis is diagnostic, allopurinol is the treatment of choice in acute gout, arthritis occur after long attacks of hyperuricemia, levels of the uric acid in the blood and severity of the gout has good correlation. So, if you take some of the options, like we know the answers already, that is synovial fluid analysis is diagnostic, that is the investigation of choice, that is what I have said you now. And arthritis occurs after long attack of hyperuricemia, that is also a true statement. And level of the uric acid in the blood and severity of the gout definitely has the good prognosis, right, definitely has good prognosis. And please remember, allopurinol is the treatment of choice in acute gout, that is the false statement, that is a false statement, okay. Allopurinol is the treatment of choice in case of the chronic gout, right, in the chronic gout. Now, having said this, let me discuss in detail about the treatment in patients with the gout or gouty arthritis. So, right, before that you see another question. All of the following statements about an attack of gouty arthritis are true except joint aspirate reveals negative birefringent crystals, allopurinol should be started immediately, colchicine is known to provide the relief, the serum uric acid levels may be normal. Now, so we will discuss the treatment and then come back to this question once again. In case of the treatment, we have two forms. One is acute gouty arthritis and the other one is the chronic gouty arthritis. So, you need to know what are the drugs given in acute attack and what are the drugs given in the chronic attack or chronic gout. That is very important. Like for example, you see a question. Drugs used in the treatment of acute gout, allopurinol, colchicine, pamidronate, methotrexate. So the drugs used in acute gout, we have three drugs. One is your NSAIDs, non-steroidal anti-inflammatory drugs. Second, we have colchicine. And third, we have the steroids. Right, third we have the steroids. Okay, so the drugs used in the treatment of acute gout, it will be your colchicine. Allopurinol, it is given in the chronic attacks, it is given in chronic gout. And pamidronate, it is a bisphosphonate, right, given in the treatment of right, it is the bisphosphonate, right, it is given in the treatment of osteoporosis. And methotrexate, this is considered as the drug of choice for rheumatoid arthritis. Okay, so the one what we give in acute attack of your gouty arthritis is colchicine. Now, so when the individual is having asymptomatic hyperuricemia, do we need to give the urate-lowering drugs? So as a general rule, the uric acid lowering drugs should not be instituted until acute gout, renal calculi or Tophi has become apparent. Okay, so please remember this point. You need to give right, you need to give the uric acid lowering drugs in case of right, in case of the acute gout. Right, you have to give this in the individual with renal calculi, and this have to be given in individuals with the Tophi formation. Okay. So in acute gout, renal calculi and Tophi, in them you need to give the uric acid lowering drugs. Asymptomatic hyperuricemia usually we avoid, but some studies suggest that treating asymptomatic hyperuricemia slow the progression of the chronic kidney disease. But some studies, they say like there is no evidence. But as a general rule, uric acid lowering drugs should not be instituted until acute gout, renal calculi and Tophi develops. So only these develop, then you give this uric acid lowering drugs. So if you see this management of gout, we have the treatment of acute gout, and to provide the rapid and safe pain relief, the drugs which are being used is the drugs which are being used is the NSAIDs. These are the most frequently used drugs to treat the gout because they are well tolerated. Okay, so these are the most frequently used drugs. Okay, most frequently used drugs to treat gout because they are well tolerated. And among these NSAIDs, which is the drug which is considered as the drug of choice? Indomethacin is the agent of choice. Right, indomethacin, it is considered as the drug of choice. But other NSAIDs may be just as effective. In the sense, the efficacy of indomethacin in your gout is highly efficacious. And usually the aspirin is avoided. Right, aspirin is avoided. Why? Because the low dose aspirin, it will increase the uric acid levels. Right, it will increase the uric acid levels. So that is the reason why usually the aspirin is avoided. Now, what are the other NSAIDs? The other NSAIDs that should be given is the naproxen. Okay, apart from indomethacin, we have the naproxen. And if you see the dosage of the naproxen is 500 milligrams twice daily. Right, 500 milligrams twice daily. Or we need to give indomethacin right, that should be in a dosage of 25 to 50 milligrams every 8th hourly. Right, 25 to 50 milligrams every 8th hourly. Okay, so these are effective treatment for acute gout and should be continued until the symptoms have resolved. So usually, they are given for almost 5 to 10 days. Right, they are usually given for almost like 5 to 10 days. Okay, now what are the contraindications for the gout or gouty arthritis? That includes number 1, peptic ulcer disease. Number 2, impaired kidney function. Right, impaired renal function. And lastly, in those individuals who have history of allergic reaction to NSAIDs. Right, history of allergic reactions to NSAIDs. So these are the contraindications of the NSAIDs in patients with your gout or gouty arthritis, because NSAIDs, they will induce the release of the acid, that is HCl, and that can precipitate your peptic ulcer disease. And NSAIDs will cause pre-renal type of acute renal failure, and it can also cause papillary necrosis. So in those individuals with renal function, please don't give NSAIDs. And in those individuals who are allergic to NSAIDs, please don't give NSAIDs. Then Then what is the alternative drug we have? The alternative drug what we have is colchicine. And colchicine, the route of administration is the oral route of administration, right? And it is an appropriate treatment option for acute gout in those individuals where we cannot give NSAIDs, okay, right? But this colchicine, it has to be given provided the duration of attack is less than 36 hours, okay? So, if the duration of attack is less than 36 hours, if you give colchicine, the efficacy will be good. Now, what is the dosage? So, if you see the dosage of the colchicine, it has to be given a loading dose of 1.2 milligrams first. That is, on day 1, you need to give a loading dose of 1.2 milligrams. And after 1 hour, right, after 1 hour, you give another 0.6 milligrams, right? After 1 hour, you need to give 0.6 milligrams 1 hour later. So, total how much? Total of 1.8 milligrams, right? Total of 1.8 milligrams that has to be given on the first day, right? That has to be given on the first day. And thereafter, how much you give? Thereafter, you have to give 0.6 milligrams twice daily. Right? You need to give 0.6 milligrams twice daily until the resolution. Right? Until the resolution. So, that is about the dosage of the colchicine. And for example, in certain patients who are already taking prophylactic doses of colchicine and now the individual had an acute flare of gout, they have to receive the full loading dose 1.2 milligrams followed by that 0.6 milligrams 1 hour later, okay. So, that is the same, but the only thing is you have to give, okay, fine, this is the dosage of your colchicine. I don't want to confuse you by adding a lot of information on the colchicine, but this will be the fine. Loading dose 1.2 milligrams and after 1 hour 0.6 milligrams, total 1.8 milligrams on day 1 and then 0.6 milligrams daily, twice daily until the full resolution. Next, now the dose has to be reduced in certain conditions, that is, colchicine dose should be reduced or avoided altogether if there is kidney or liver impairment, okay. So, if there is kidney or liver impairment, right, if there is kidney or liver impairment, the dosage of the colchicine has to be reduced. And the use of oral colchicine during the intercritical period to prevent gout attacks, I will tell you now, okay. During the intercritical period, do we need to give or not? But remember, whenever there is kidney or liver impairment, you should not give the colchicine. That is an absolute contraindication. Then, the next important drug like what we have in acute attack is the steroids. Corticosteroids, they often give dramatic symptomatic relief in acute episodes of gout and will control the most attacks. They are most useful in patients with contraindications to the use of NSAIDs. So, when will you give this corticosteroids? Wherever there is contraindications to NSAIDs, you need to give these particular steroids. And these particular steroids, they have to be given intravenously, right? They have to be given intravenously. And the intravenous steroid that we give is methylprednisolone. And this has to be given at a dosage of 40 milligrams per day. And then the steroid can also be given through the oral route. The oral route steroid what we give is prednisolone. and this has to be given at a dosage of 40 to 60 milligrams per day. Okay, so this is about the dosage of your steroids. And the steroids can be given at the suggested dose for 5 to 10 days, right? So you have to give for nearly around 5 to 10 days. Or the other way of supplementation of the steroids is that the other way. See, initial dose, right? Initial dose, that is, you have to give for 2 to 5 days, and then you taper over 7 to 10 days. That is how you can supplement the steroids. Either you give this full days for 5 to 10 days and then stop, or you give the initial dose for 2 to 5 days and then taper over 7 to 10 days. Because you have to give the tapering dose only when you have given the steroids beyond 1 week. For suppose when you are giving steroids only for 5 days, tapering is not required, you can stop it, right? Beyond 1 week to 10 days if you are giving the steroids, then the tapering is required. Okay. Now, apart from that, there are certain scenarios where you have to give the intra-articular steroid supplementation also. That is, if the individual is having gout in monoarticular, that means only single joint is affected, in such case you need to give intra-articular injections, and that includes, right. So if there is monoarticular arthritis, you need to give the intra-articular steroid, and that particular intra-articular steroid that has to be given is the triamcinolone, right? That is triamcinolone, and the dosage of triamcinolone is 10 to 40 milligrams depending upon the size of the joint. Okay, and you have to understand that because gout and septic arthritis, it can coexist, joint aspiration and gram stain with culture of the synovial fluid should be performed when intra-articular corticosteroids are given, because when you are giving the intra-articular corticosteroid, it can suppress the immunity in that particular area, and upon that, if there is coexisting septic arthritis, there will be precipitation of the septic arthritis. So that is the reason why before giving this particular the intra-articular steroid, it is better that the synovial fluid has to be aspirated and then the examined. Okay, so that is about like when you should give triamcinolone. When there is gout in monoarticular, then intra-articular administration of the corticosteroids has to be given. Then the other group of drugs like what we have is the interleukin-1 inhibitor. Okay, so the drug like what we have is anakinra. So this anakinra, it is an interleukin-1 receptor antagonist. Right, interleukin-1 receptor antagonist. And another interleukin-1 inhibitor what we have is canakinumab. Right, canakinumab. Okay, so this canakinumab, it is a monoclonal antibody against the interleukin-1 beta. Okay, it is a monoclonal antibody against interleukin-1 beta. Okay, so these drugs, they have the efficacy for management of the acute gout. Right, these drugs, they have the efficacy for the management of the acute gout, but these drugs have not been approved by FDA for this indication. Okay, they are not FDA approved, but definitely yes, they have efficacy for the management of the acute gout. So after having discussed about the drugs used in the treatment of the acute gout, let me just discuss about the urate-lowering therapies. So the indications for the pharmacological urate-lowering therapy in patients with history of gout are: number 1, in those individuals who have recurrent attacks of gouty arthritis. right, in those individuals with recurrent attacks of gouty arthritis. And the second indication is in those individuals who have clinical or radiographic signs of chronic gout. Okay, so clinical or radiographic signs of chronic gouty arthritis. And third important indication is in those individuals who have the tophaceous deposits in the soft tissue or subchondral bone, right? So in those individuals with tophaceous deposits in the soft tissue and subchondral bone. And the fourth important indication is in individuals with gout with renal insufficiency. Right, gout with renal insufficiency, right, that is another indication for the urate-lowering therapy. And the next is recurrent nephrolithiasis. Okay, so these are the indications for the urate-lowering therapy. And lastly, the another important indication is where there is urinary uric acid excretion almost like 1100 milligrams per day. Okay, so when the urinary uric acid, right, if it is in a range of, or if the urinary uric acid excretion is in a range of 1100 milligrams per day, that is also another indication for the pharmacological urate lowering therapy. Now, there are three options. What are all the urate lowering therapies? There are three options available for reducing the serum urate concentration. Number one, the uric-uric drugs. These are the drugs causing renal excretion of the uric acid. Right, number one, the uric-uric drugs. Right, so uric-uric drugs, what is the mechanism of action is, these are the drugs which will cause the renal excretion of the uric acid. And the next thing is, we have the drugs which will inhibit the uric acid synthesis. Right, which will inhibit the uric acid synthesis. And the third important is the uricase. Okay, so which is nothing but pegloticase. Okay, so these are the three options available for reducing the serum urate concentration. Now, first let me take up the discussion of the uric-uric agents. Uric-uric agents, the examples like what we have is the probenecid. Probenecid, it is the most commonly used the uric-uric drug. Okay, so we have probenecid, and the second important drug is benzbromarone, and lastly we have sulfenpyrazone. So these are the three uric-uric agents. Now these uric-uric agents, let me tell you, they are weak organic acids. Right, they are the weak organic acid. And what these uric-uric agents do is, they promote the renal excretion of the uric acid by inhibiting urate anion exchanger. So in the proximal convoluted tubule, right, in the proximal convoluted tubule, you have a urate anion exchanger. Right, and this urate anion exchanger, which is present in the proximal convoluted tubule, this will mediate the absorption of the urate. Right, this will mediate the absorption of the uric acid. Okay, now these uricosuric agents, what they do is they inhibit, right, this probenecid or the other drugs, they inhibit the urate anion exchanger which is present in the proximal convoluted tubule, and thereby the urate absorption does not occur, and thereby it acts as the uricosuric agent. Okay, so that is the mechanism of action of the drugs of the probenecid or benzbromarone or sulfenpyrazone. So what is the site of action of these particular drugs? The site of action of these particular drugs is at the level of the proximal convoluted tubule. And what they do? They increase the uric acid excretion by the kidney. So what will be the limitation of these drugs then? If there is any renal insufficiency, then in such case you cannot use this particular uricosuric agents. Now apart from probenecid, we have another very important drug which has been recently approved, that is Lesch-Nyhan. Okay, see, this is also a recently approved drug. So if you see the dosage of the probenecid, you have to give 0.5 grams per day, and the route of administration of this probenecid, it is the oral route of administration. Okay, and you take this Lesch-Nyhan, the dosage is 200 milligrams per day. And the route of administration of this particular drug is the oral route of, okay, so it has to be given, okay, it has to be given orally. Okay, and these are the uricosuric agents of choice. But remember, these are typically reserved for patients who cannot achieve the serum uric acid levels of less than or equal to 6 milligrams per deciliter with allopurinol or febuxostat. Actually, in urate-lowering drugs, the first group of drugs what we give is allopurinol, that is xanthine oxidase inhibitors. That is the drugs which will inhibit the uric acid synthesis. That will be the first line drugs in the urate-lowering therapy. In spite of using the urate-lowering therapy, if the serum uric acid levels does not decrease less than 6, then you need to add this probenecid and as well as the Lesch-Nyhan. Okay. Now this Lesch-Nyhan, it carries an FDA black box warning that acute kidney injury can occur with this treatment. Okay. So Lesch-Nyhan, it can cause, right, it can cause acute kidney injury. That is the black box warning given by your FDA. Okay, and the chance of development of acute kidney injury with Lesch-Nyhan increases, right, increases if it is given without a xanthine oxidase inhibitor. Okay, so if this Lesch-Nyhan is given without a xanthine oxidase inhibitor, then the chance of acute kidney injury is increased, right? The chance of acute kidney injury is increased. Okay, but when you give this Lesch-Nyhan along with a xanthine oxidase inhibitor, then in such case the chance of the acute kidney injury is reduced, right? And remember, this Lesch-Nyhan, it is contraindicated in patients with creatinine clearance less than 45 ml per minute. Okay, so in patients where the creatinine clearance is less than 45 ml per minute, right? So in this group of individuals, Lesch-Nyhan is contraindicated, right? That should not be given. Okay, and you take this probenecid. Probenecid can be added to xanthine oxidase inhibitor, or it can be used as monotherapy, right? It can be used as a monotherapy, or it is given in combination. right, or it is given in combination. So please remember this. Whereas lesinurad, it has to be given in combination only. But whereas probenecid, it can be given either alone or in combination. Okay. Next, then followed by that, there are certain contraindications for uricosuric agents, right? I was just discussing that. What are the contraindications? They are usually avoided if the patient has the chronic kidney disease, right? Because the effect of the uricosuric agents is by acting on the proximal convoluted tubule. If the kidney itself is damaged, right, then the action of the probenecid will not be there. Okay. And if the individual or if the patient is having the history of urolithiasis or Tophi, right, if the patient is having the history of urolithiasis or Tophi, the uricosuric drugs, they are avoided. And if the patient is having mild to moderate renal insufficiency, right, if the patient is having mild to moderate renal insufficiency, the uricosuric drugs, they are avoided. Okay. So this limits the use of uricosuric drugs, and they are generally used as the second line drugs compared to that of the xanthine oxidase inhibitors. So the first line drugs for uric acid reduction is xanthine oxidase inhibitor, that is your allopurinol or febuxostat. Whereas these uricosuric drugs, they are used as the second line agents, right? They are used as the second line agents. Okay. Now coming to your xanthine oxidase inhibitors. So if you take this xanthine oxidase inhibitors, that is mainly the allopurinol and febuxostat. So if you take this allopurinol and febuxostat, what exactly they do? So if you take the uric acid synthesis, the cycle, hypoxanthine is converted into the uric acid, and hypoxanthine is converted into uric acid in the presence of the enzyme xanthine oxidase. So this allopurinol, what it will do? It will inhibit the xanthine oxidase. So once it inhibits the xanthine oxidase, then the uric acid is not synthesized. So basically it will inhibit the uric acid synthesis, right? It will inhibit the uric acid synthesis. And this allopurinol, let me tell you, it is given as the first line anti-hyperuricemic therapy for most patients in whom urate lowering is indicated. So this will be the first line agent. So in those individuals, whomever you have planned for urate lowering therapy, allopurinol has to be given first. Okay. And if you take the febuxostat, even your febuxostat is also, right, this is also a xanthine oxidase inhibitor, right? This is also a xanthine oxidase inhibitor, but the only difference is it has slight structural and metabolic difference. Okay, so there is different structural and metabolic properties. And this febuxostat, it is provided as an alternate agent for urate lowering therapy. This is not first line. Okay, so this is used as an alternate agent for urate lowering. And in which group of individuals we give this febuxostat? In those individuals who are intolerant to allopurinol. Right, in those individuals who are intolerant to allopurinol, there we give this particular febuxostat. Now, what will be the dosage of your allopurinol and what will be the dosage of your febuxostat? So, if you take the dosage of the allopurinol, the initial daily dose of allopurinol is 100 milligrams per day. right? It is 100 milligrams per day. And the route of administration is the oral route of administration, right? And in individuals with chronic kidney disease, you have to reduce the dose, okay? So, in individuals with chronic kidney disease, the dosage is 50 milligrams per day. So, mainly when the individual is in stage 4, right? When the individual is in stage 4 chronic kidney disease, the dosage is the 50 milligrams per day, right? And this particular dosage of allopurinol should be titrated upwards every 2 to 5 weeks to achieve the target serum uric acid level, okay? So, every 2 to 5 weeks, you need to increase the allopurinol dose, that is to achieve, right, that is to achieve the target serum uric acid levels. Okay, next. Now, a typical dose of allopurinol is 300 milligrams, but most patients require greater than 300 milligrams daily to achieve this target uric acid level. So, initially you start with 100 milligrams per day, but every 2 to 5 weeks you need to increase to achieve the target serum uric acid level. So, most of the patients to achieve this serum uric acid levels, they will be requiring around 300 milligrams per day, right? And what is the maximum daily dose that you can give? Maximum daily dose that you can give is 800 milligrams, right? It is 800 milligrams. So, that is the dosage of the allopurinol. Next, if you take the next drug, that is Febuxostat. So, FDA advises that Febuxostat should be reserved for patients in whom allopurinol is ineffective or contraindicated, right? So, it should be reserved in individuals who have, right, who are intolerant to allopurinol, right, who are intolerant to allopurinol, okay? And FDA has given the black box warning that in individuals who are taking Febuxostat, they are at higher risk of death, right? They are at higher risk of death in individuals who are taking this Febuxostat. And what is the initial dose? The initial dose of the Febuxostat is around 40 milligram per day, and the route of administration of this Febuxostat is the oral route of administration, okay? And you are giving around 40 milligrams per day. If the target serum uric acid is not reached in 4 weeks, the Febuxostat can be increased to 80 milligrams per day, okay? So, you have to give 40 milligrams per day. If the target is not reached in 4 weeks, right, if the target is not reached in 4 weeks, this can be increased to 80 milligrams per day, right? The dose can be increased to 80 milligrams per day, okay? And what is the maximum dose that you can give? The maximum dose of the Febuxostat is 120 milligrams per day, right? Maximum dose is 120 milligrams per day. So, that is about the story related to your Febuxostat. Then, we have another urate-lowering therapy, that is the uricase, which is nothing but the pegloticase. Pegloticase, it is a recombinant uricase that must be administered intravenously, okay? So, this is a recombinant uricase. And what is the route of administration of this pegloticase is intravenous route of administration, and this has to be given, the dosage is 8 milligrams every 2 weeks, right, 8 milligrams every 2 weeks, okay, and it is indicated for the rare patient with refractory chronic tophaceous gout, okay. So in individuals with refractory chronic tophaceous gout, right, in individuals with refractory chronic tophaceous gout, you need to give this particular pegloticase, right, and the pegloticase also carries an FDA black box warning which advises administering the drug only in healthcare settings and by healthcare professionals prepared to manage the anaphylactic and other serious infusion reactions, okay. So this is associated with anaphylactic reactions, okay. So that is a black box warning by the FDA. So it has to be administered by those individuals, or it has to be administered in that particular setting where the anaphylactic reactions can be handled. So that is about your pegloticase. This is also a drug which will decrease the uric acid levels. Next, now if you take this clinical entity, that is chronic tophaceous arthritis with rigorous medical compliance like allopurinol, Febuxostat or pegloticase, that will shrink the tophi, and in time it can lead to their disappearance also, right, it can lead to their disappearance also. And resorption of this extensive tophi requires a maintaining a serum uric acid below 6 milligrams per deciliter, okay. So with good medical compliance, right, with good medical compliance, right, what is that? Either you are giving allopurinol, right, or you are giving Febuxostat, right, or you are giving pegloticase, so whenever you are giving these drugs, they will shrink the tophi, right, they will shrink the tophi, and in time they can lead to their disappearance. And in order to shrink the tophi, the resorption of the extensive tophi requires a maintenance of the serum uric acid levels less than 6 milligrams per deciliter, right, less than 6 milligrams per deciliter, okay. And when there is mechanical problem within the joint, like for example, if there is large tophi, this can cause, right, this can cause the mechanical impairment of the joint. So when there is large tophi, surgical excision of large tophi offers mechanical improvement in selected deformities. So when there is large tophi causing mechanical impairment, surgical resection has to be done, right. So that is about the chronic tophaceous gout. So chronic tophaceous gout is basically like you have to ensure that the tophi has to be reduced, means the serum uric acid levels should be less than 6 milligrams per deciliter, and if it is a large tophi, surgical excision has to be done. Now, what is the incidence of gout in the transplant patient? See, hyperuricemia and gout commonly develops in many transplant patients, right, in many transplant patients because they have decreased kidney function. Okay, so these transplant patients, they have decreased kidney function. So because they have this decreased kidney function, remember these patients who have undergone transplant, they are at increased risk of the hyperuricemia. They are at increased risk of hyperuricemia. Okay, and not only that, these patients who have undergone transplant, they require the drugs, right? They require the drugs that inhibit the uric acid excretion. So what are the drugs that inhibit the uric acid excretion is? That particular drugs include cyclosporin and diuretics. And why is that you need to give cyclosporin? Right? Why is that you need to give cyclosporin in this individual is because this particular cyclosporin, right? Because this cyclosporin in transplant patients, they act as the immunosuppressive agent. Because we don't want the transplant rejection to occur. So, in order to reduce the immunity of the individual, we give this cyclosporin. But the problem with the cyclosporin is that it will inhibit the uric acid excretion. Okay. So, because of these two reasons, the chance of development of gout or hyperuricemia is very high in the transplant patients. Okay. So, for example, right, if the individual has developed monoarticular gout, then how do you treat? So, if the individual has developed the monoarticular gout, after excluding the infection within the joint, you need to inject the corticosteroids, right? And what is that you will give? That is triamcinolone. That is your triamcinolone. Okay. Next, then for example, if the individual has polyarticular gout, if it is monoarticular gout in a transplant patient, no problem, you will inject the steroid. But for polyarticular gout, increasing the dose of systemic steroid may be only alternative. Okay. So, for polyarticular gout, you need to increase right, you need to increase the dosage of the systemic steroids. Okay, right. So, that is about the treatment of the gout in the transplant patients. And next important point is that, right, the kidney dysfunction seen in many transplant patients make the uricosuric agents ineffective. Just now we were discussing probenecid, benzbromarone, sulfenpyrazone, they are not effective in kidney dysfunction patients. So, you need to give the drugs which will decrease the uric acid synthesis. So, please remember, in transplant patients, right, you should not give the uricosuric agents. Right, you should not give the uricosuric agents. So, what is that you need to give? Allopurinol and Febuxostat. So, these drugs, they will inhibit the metabolism of azathioprine. Azathioprine is another drug given in the treatment of transplant as an immunosuppressant. So, allopurinol or your Febuxostat, they inhibit the metabolism of azathioprine and should be avoided in patients who take azathioprine. So, in gout in transplant patients, you cannot give uricosuric agents. The only alternative agents is the allopurinol and as well as Febuxostat. But only point you have to remember is that this allopurinol and Febuxostat, they can inhibit the metabolism of the azathioprine. So in those individuals in whom you are giving azathioprine, you should not give this allopurinol and febuxostat also. Okay, azathioprine, why we are giving in transplant patient? In order to suppress the transplant reject reaction. For that we give this azathioprine. So this is about the story of gout in transplant patient. So please remember, in transplant patient there is increased risk of gout. The reason is that in transplant patient the kidney function is impaired and we give the drugs which will inhibit the uric acid excretion, like example like cyclosporine, and the treatment for them is that you need to give only allopurinol and febuxostat, because you cannot give the uric-uric agent because they have impaired renal function. And again this allopurinol and febuxostat also, please remember, you should not give in those individuals who is taking azathioprine, because these drugs they will inhibit the metabolism of the azathioprine. So if you see a question here, false regarding the gouty arthritis is synovial fluid analysis is diagnostic, allopurinol is the treatment of choice in acute gout, arthritis occurs after a long attack of hyperuricemia, levels of the uric acid in blood and severity of the gout has good correlation. Just now we have discussed, what did I tell you? Allopurinol is the one which is not given for acute attack, it is mainly given for the chronic gouty arthritis. So you have to remember certain important facts about the gout. First point, gout is the common endpoint of group of disorders that produce the hyperuricemia. Okay, so wherever there is increase in the uric acid levels, there is high chance of development of gouty arthritis. But please remember, all those individuals who have developed hyperuricemia will not develop your gout or gouty arthritis, right? And how is that you will define hyperuricemia? Hyperuricemia is defined as the serum urate concentration more than 7 milligrams per deciliter. Right, when the serum urate concentration is more than 7 milligrams per deciliter, that we call it as the hyperuricemia. And not all the patients with hyperuricemia will develop your gout. That is what I was telling you. Most of the persons with hyperuricemia remain asymptomatic and clinical gout develops in fewer than 1 in 4 hyperuricemic patients. Okay, so most of the persons with hyperuricemia they remain asymptomatic. 1 in 4 patients, right, 1 in 4 patients they develop gout or gouty arthritis. Okay, and the other point is, the initial episode of acute gouty arthritis usually follows 10 to 30 years of asymptomatic hyperuricemia. So almost the individual will remain asymptomatic for nearly around 10 to 30 years, right? And what is the drug of choice for chronic gout? Allopurinol is the drug of choice for chronic gout. And what is the drug of choice for acute gout? That is NSAIDs. NSAIDs, these are the drug of choice for acute gout. Okay, so these are some summarizing points or nutshell points regarding your gouty arthritis, right? Then followed by that, let me discuss the complications in patients with the gout. That includes, so if you see this question, all of the following conditions are observed in gout except uric acid nephrolithiasis, deficiency of enzyme xanthine oxidase, increase in serum urate concentration, renal disease involving interstitial tissue. Okay, so this is about like renal complications. Right, let me discuss what exactly happens and then we will come back to this question. So one of the most anticipated complication in your gout is the renal complication. Okay, so in the past, progressive renal failure has been common in the gouty arthritis population, with up to 25% of patients with gout dying of the renal disease. Okay, so one of the very important complication that you will encounter in patients with gout is progressive renal failure. Right, progressive renal failure. Okay, that has been common in the gouty population with up to 25% of patients. Okay, and this renal complications include, that is, gouty nephropathy or the chronic urate nephropathy. And what exactly happens here? What happens is, in patients with gout, there is increase in the monosodium urate crystals. So, this increased monosodium urate crystals, right, this increased monosodium urate crystals, they go and get deposited in the renal medullary interstitium. Right, they go and get deposited in the renal medullary interstitium. And not only in renal medullary interstitium, they also deposit in the renal tubules. And in which part of the renal tubules this monosodium urate crystals are being deposited is, that is in the distal, right, that is in distal and as well as the collecting tubules. So here the monosodium urate crystals are being deposited. And by depositing within the tubules, that will cause the tubular obstruction. Right, that will cause the tubular obstruction. So, tubular obstruction by urate crystals, that will cause the cortical atrophy and as well as the scarring. Okay, so that will cause right, that will cause the cortical atrophy and as well as the renal scarring. Right, and not only this cortical atrophy and scarring, they may also cause the pyelonephritis due to urinary obstruction. So, these urate crystals will also cause the urinary obstruction. So, once there is urinary obstruction, there can be development of the pyelonephritis. So, what is this pyelonephritis? That is the infection of the renal parenchyma. Why is that occurring? Because once there is urinary obstruction, the urine gets accumulated within the entire urinary tract and that gets infected, resulting in the pyelonephritis. Okay. And the other point is that although chronic hyperuricemia is thought to be the cause of this urate nephropathy, this form of kidney disease is never seen in the absence of the gouty arthritis. So, it is your gouty arthritis first, then followed by that there will be development of chronic urate nephropathy, right? Without the development of your arthritis first, directly it is very unusual to develop the urate nephropathy, right? So, although chronic hyperuricemia is thought to be the cause of this urate nephropathy, this form of kidney disease is never seen in the absence of the gouty arthritis, right? Now, coming to your nephrolithiasis. This is another important complication in gout. This nephrolithiasis, it develops in 10 to 25% of patients with gout. Right, in 10 to 25% of patients with gout, right, there is development of your nephrolithiasis. This will occur at some time during the disease course. And the incidence of nephrolithiasis correlates with the serum urate levels, but more strongly with the amount of the uric acid excreted in the urine, right? So, the increased incidence of nephrolithiasis is seen in those individuals in whom where there is increased uric acid in the urine. Right, in individuals where there is increased uric acid excretion, that is strongly associated with the development of your nephrolithiasis, right? More is the uric acid getting excreted through the urine, there is a higher is the chance of development of your nephrolithiasis, but that is seen only in 10 to 25% of patients with gout. And most of these calculi, they are composed of the uric acid, okay? So they are the uric acid crystals. Right, they are your uric acid crystals. But remember, calcium containing stones are 10 times more common in patients with gout than compared to that of the general population. So that is, not only uric acid crystals, even calcium containing stones, right, even the calcium containing stones, right, almost like 10 times more common, right, 10 times more common then compared to that of general population, 10 times more common in patients with gout then compared to that of the general population. So that is about your nephrolithiasis, right, urate crystals, and seen in almost 10 to 25% of patients with your gout or gouty arthritis. Then we have another clinical entity called acute uric acid nephropathy. So we have two forms, one acute we have and chronic we have. So if you see this acute uric acid nephropathy, this type of nephropathy is particularly likely to develop in patients with leukemias and lymphomas, okay. So in those individuals, right, in those individuals who have leukemias and as well as lymphomas, right, in those individuals who has taken chemotherapy. So this chemotherapy will kill the leukemic cells and as well as the lymphoma cells, and that will cause the release of the uric acid into the circulation, okay. So what these particular chemotherapy drugs do, these particular drugs increase the death of the tumor cells. Right, they will increase the death of the tumor cells, okay, and thereby there is increased uric acid, right, there is increased uric acid released into the circulation, and that increased uric acid which is released into the circulation, it precipitates in the renal tubules. Right, it precipitates in the renal tubules, particularly it precipitates in the collecting ducts. Right, particularly it precipitates in the collecting ducts, okay, and once it precipitates in the collecting ducts, that leads to the obstruction of the nephrons. Right, that leads to the obstruction of the nephrons, and that will subsequently lead to the development of the acute renal failure, okay, that subsequently leads to the development of acute renal failure, okay. Next, then having discussed about the acute uric acid nephropathy, next thing is you need to know about the chronic urate nephropathy. So chronic urate nephropathy, it is a form of chronic kidney disease induced by deposition of the sodium urate crystals in the medullary interstitium, right. So there is deposition of sodium urate crystals in medullary interstitium, okay, that will make the individual to develop the chronic urate nephropathy, okay. And this sodium urate crystals, they will cause the chronic inflammatory reaction, right, they create a chronic inflammatory reaction, or they will induce right? They will induce the chronic inflammatory reaction or response leading to the development of interstitial fibrosis, right, leading to the development of the interstitial fibrosis and the chronic kidney disease. Okay, so these are the two inflammatory responses that will occur in response to the deposition of the sodium urate crystals in the medullary interstitium, that is interstitial fibrosis and the chronic kidney disease. Now, having said this, if you see the question, all of the following conditions are observed in gout except uric acid nephrolithiasis, deficiency of enzyme xanthine oxidase, increase in serum urate concentration, renal disease involving the interstitial tissues. So, uric acid nephrolithiasis, it is seen in almost 15 to 25% of individuals, and there is also increase in the serum urate concentration, and there will be also development of the renal disease involving the interstitial tissues. And remember, deficiency of the enzyme xanthine oxidase is not seen in patients with your gout or gouty arthritis. In fact, what is that you want? The xanthine oxidase enzyme has to be inhibited in your gout, and that is what is being done by your allopurinol. Alright, next. So, you see the next question, the clinical features of the gout: pain, inflammation of the joint, small joint involvement, crystal deposition at the synovium, chondrocalcinosis. Let me tell you, in patients with gout, all of these features are present. Right? All of these features are present. Pain, inflammation of joint, small joint disease will be there, crystal deposition at the joint synovium will be there, and there will be also development of the chondrocalcinosis. Alright, next. Next question is, in case of gout, precipitation of urine sample is done in normal saline, formalin, alcohol, distilled water. So, in case of gout, the preservation of the urine sample has to be done in the alcohol, right? This is a very, very important multiple choice question. Then overall, how will be the prognosis in these patients with your gout or gouty arthritis? See, without treatment, the acute attack may last from a week, from few days to several weeks. Okay, so, right, without treatment, the acute attack, it may last from few days to several weeks, and the interval between the acute attack vary up to years, but the asymptomatic periods often become shorter if the disease progresses. Okay, so they have the recurrent attacks. So the interval, right, the interval between the acute attacks, let me tell you, they vary up to years, right, they vary up to years, but this asymptomatic periods, right, that is intervals, that is asymptomatic periods, they become shorter as the disease progresses. Okay, so this is a very important point that you have to remember, right? As the disease progresses, the asymptomatic periods, they become shorter. And you take chronic gouty arthritis, acute gouty arthritis, if you don't treat, it will last for few days to several weeks. Chronic gouty arthritis occurs after repeated attacks of the acute gout, but only after inadequate treatment. Okay, so the same acute attacks, if the recurrence is very high, right, and you have given an inadequate treatment, then in this case right? In this case, there is increased incidence of there is increased incidence of the chronic gout, okay? And the younger the patient at the onset, the greater the tendency to a progressive course. That is another important prognostic point, right? At the onset, if the individual is younger, there is greater tendency to a progressive course, right? And what about the destructive arthropathy? Destructive arthropathy, it is rarely seen, right? It is rarely seen in patients whose first attack is after the age of 50 years. For suppose, if the individual is at younger age, at the onset, the chance of developing the destructive arthropathy is more. But if the individual is having the onset of the disease after 50 years, then the chance of destructive arthropathy is rare. So, the prognosis is that without treatment, the acute attack may last from few days to several weeks. The interval between the acute attacks vary up to years, but the asymptomatic periods often become shorter if the disease progresses. And chronic gouty arthritis occur after repeated attacks of acute gout, but only after inadequate treatment. And younger the patient at the onset of the disease, greater the tendency of a progressive course, right? And the destructive arthropathy is rarely seen in patients whose first attack is after the age of 50 years. So, this is about the prognosis in individuals with the gout or gouty arthritis. Now, let me discuss some clinical questions in the topic of gout. So, if you see this clinical question, the question is, you are seeing Mr. Hinsley, a 72-year-old man with only history of hypertension on the hydrochlorothiazide. He presents today with acute excruciating knee pain. On examination, his knee is warm, mildly erythematous, swollen and tender to touch or passive movement. Microscopic examination of the joint fluid is shown in the figure. What is Mr. Hinsley's most likely metabolic derangement? The options are acute bacterial joint infection, antibodies to anti-nuclear antigen, hyaline cartilage degeneration, increased production of inorganic pyrophosphate, uric acid overproduction. So, from this question, what I want to tell you is, your acute gouty arthritis is not just seen only in your first metatarsophalangeal joint. It can also affect even the knee joint. And you can observe the microscopic examination picture where you have the presence of the monosodium urate crystals, like which are the needle shaped. Okay, so you can observe this needle shaped crystals. Okay, so these are the needle shaped crystals. Okay, and during the acute attack, these crystals will be intracellular, and once the acute attack subsides, these crystals, they are the extracellular. Okay, and in case of acute bacterial joint infection, the individual will have the presence of fever as well, but that is not seen in this particular history. And if you see the hyaline cartilage degeneration, the hyaline cartilage degeneration, it is typical of the osteoarthritis, right? It is typical of the osteoarthritis. And in osteoarthritis, it is most of the time it will not be unilateral, most of the time it will be bilateral. And age will correlate, whatever the age of the individual is there, that will go with your osteoarthritis, but most of the times it will be unilateral. Okay, right. Then followed by that, you take the antibodies to anti-nuclear antigens. ANA, they are typical for the lupus, right? They are typical for lupus, and in lupus you have to remember that there will be development of synovitis. Erosive arthritis is not the feature of your lupus at all, and in these patients with lupus you don't have the presence of the crystalline fluid. Okay, and in case of bacterial infection, not only fever, if you take the aspirate, it should be purulent. It should be purulent. Okay, and the next is increased production of the inorganic pyrophosphate. So, increased production of inorganic pyrophosphate is the cause for CPPD crystals, right? And the CPPD crystals, you will have that in patients with the pseudo gout. Okay, and this is the question, the answer being the uric acid overproduction. So, this is a case of clear-cut case of the gout or gouty arthritis. And in case of the pseudo gout, if you do a synovial fluid analysis, you have the presence of the rhomboid shaped crystals that I have already shown you in my previous discussion, right? Next, you see another clinical scenario. You are planning to start allopurinol for Miss Maggie for a new diagnosis of gouty arthritis. Which of the following best describes appropriate dosing strategies for allopurinol? The options are allopurinol and azathioprine are commonly used together in the treatment of gout. Allopurinol dosing should be adjusted for liver function. Allopurinol dosing should be titrated to achieve the serum uric acid levels less than 6 milligrams per deciliter. Allopurinol should be avoided when patients are taking colchicine. Allopurinol toxicity is more common in patients expressing the HLA-B27. So, what is the correct statement in this? You have to adjust the dosage of allopurinol. Allopurinol, actually we start with 100 milligrams per day, but you have to adjust this particular dose until the serum uric acid level becomes less than 6 milligrams per deciliter. And what is your allopurinol? Allopurinol, it is xanthine oxidase inhibitor, and that is the one which will decrease the uric acid synthesis. That is the one which will decrease the uric acid synthesis. And initially the dosage what we start is 100 milligrams per day, and maximum that you can give is 800 milligrams per day, right? Maximum dose that you can give is up to 800 milligrams per day, right? And in patients with the chronic renal disease, you have to adjust the renal dose. Okay, so it is not the dose to be adjusted with the liver function, the dose has to be adjusted for renal function. Right, the dose has to be adjusted for the renal function, not for the liver function. Okay, right. Then followed by that, you take the HLA-B27. HLA-B27 is seen in patients with the psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, retarded or reactive arthritis. And in patients with HLA-B27, if you give allopurinol, you know, the allopurinol toxicity is more common. This is a wrong statement. But in which group of individuals the allopurinol toxicity is more common is in those individuals who are expressing HLA-B5801. In these individuals, the chances of the allopurinol toxicity is more common. Okay, right. Then the next important point is about the colchicine. Colchicine, let me tell you, it can be commonly used. Both of these drugs, it can be safely combined. Right, both of these drugs can be safely combined, no problem at all. And about allopurinol and azathioprine. Okay, allopurinol and azathioprine should not be co-prescribed because azathioprine can greatly increase the blood levels of the allopurinol and it will lead to toxicity. Okay, so both these combinations, right, they are deadly combinations. So this azathioprine will increase the levels of the allopurinol. So you should not combine both these particular drugs. So these are some of the clinical questions about your gout or gouty arthritis. Thank you very much.